welcome to the second episode of Pharmacy Forward, Insights from Insiders. I'm Lesley Pink, your host. Today we'll be talking about medical rebates with two members of the Gateway Health Partners team. They are Sam Warman, Vice President of Client Consulting, and Azim Bari, Chief Clinical Officer. Sam started working on the medical rebates program at Gateway in 2019. Azim has been with the company since 2017 and leads clinical operations. Sam and Azim, welcome to the podcast.
Thank you.
Thank you.
First off, Sam, would you explain the difference between pharmacy rebates and medical rebates?
The primary difference is going to reside where the drugs originate. Medical rebates focus around drugs that are administered through the medical benefit, typically drugs that are administered in a doctor's office or maybe at home, but in a different setting than would be the pharmacy, right? Pharmacy is with rebates are going to surround drugs where you go to a pharmacy and pick up your medications for blood pressure or whatnot. Medical rebates reside around drugs that are typically administered by a healthcare professional.
Okay, and why do medical rebates exist in the first place?
Well, many of the products that are in a medical benefit are expensive, and typical cost savings strategies reside around prior authorizations or step therapies. Medical rebates offer an additional cost-saving tactic by providing discounts off of the cost of the medication, depending on their placement in formularies.
And what types of drugs are included, and would cell and gene therapies be included?
So I'll answer the second one first. Yes, they are included. We're seeing that as a growing space in medical rebate programs as these drugs are coming out for some therapies that typically are very hard to treat and are rare in most cases. But the rest of the medications out there can be simply drugs that are used for oncology. They can be used for multiple sclerosis, other rare or orphan drug therapies, cancer support, as well as anti-inflammatory conditions.
Okay, and how do these drugs get placed on formularies, and is there a class of drugs that gets placed on there more than others?
That's a really good question. Right now, there are a number of anti-inflammatory condition products in medical rebate programs. These drugs treat conditions like Crohn's disease, ulcerative colitis, and a number of other inflammatory conditions. Those represent probably the largest therapeutic class we see in medical rebate programs, but there are others out there to support, like long-acting and short-acting colony-stimulating factors represent a good size of products on there. They follow the same path as any other product in being placed on a formulary. So, monitoring the pipeline, trying to understand sort of the clinical efficacy and the protocol surrounding the drug, and then have a P&T review those recommendations and provide those forward, and then look at the business side of things, and then placing them on the formulary based on not only their clinical efficacy, but does it represent a cost-effective product to be placed there.
Okay, Azim, do you have anything to add to that?
Yeah, I was just going to add that, it's similar. There are some similarities to pharmacy in that, all of the stuff that Sam just mentioned in terms of what drugs get added to the formula or for coverage under the medical rebates is 100% true. But there's also that competitive landscape. When we have drug classes that have, that are competitive and have many products with minimal clinical differentiation, as is the case in many times, then the manufacturers are incentivized then to get more aggressive with pricing. And one of the mechanisms by which they do that is rebates, not only on the pharmacy benefit, but also for the medical rebates. But unlike pharmacy, medical is, it's very different. It's a different type of drug. As Sam mentioned, these are more complex, typically complex drugs, those administered by the healthcare provider. It's been a little bit slower to the game in getting enough products where things are competitive in certain classes. But, as Sam will attest to, over the last 5 years, it's accelerated. And now we have, a very long list of drugs that are on the medical rebates program across many different classes that are competitive. So they are looking for that differentiation in terms of financial impact if all clinical aspects of the drug are fairly similar within the drug class.
Got it. And who manages these medical rebate programs?
It's a number of entities. First, health plans can manage their own medical rebate programs themselves, or they can outsource that to many entities like Gateway Health Partners. There are the big three out there have programs as well. So it can be any of those organizations, and it can be a mix of the organizations in many cases.
Okay. And now let's talk a bit about legislation and any effects on medical rebates. We had a previous podcast where we were talking about the effects of the IRA on drug costs. Is there any recent legislation you can think of that might have an effect on medical rebates?
Yeah, the first two that come to mind, Leslie, is the Inflation Reduction Act. Typically, that's been, or most recently, that's been surrounding more Part D as in David drugs, where it's the oral, the pharmacy benefit type drugs. But now we're seeing Part B as in boy drugs, which those drugs mainly reside in medical benefits and pertain to many of the medical rebate products that we have. We're seeing those being entered into the negotiations. So there's going to be some impact there. That remains to be seen how that's going to impact prescriber influence and what it does to maybe market shares within therapeutic categories. The other one comes to mind, and we've been getting some questions about it recently, and it impacts more than just medical rebates, but it does have is the Consolidated Care Act of 2026. There's a lot of unknowns still associated with it. The regulations haven't been finalized, but there's going to be some reporting differences, things that are going to have to be supported, like from Gateway Health Partners down to our clients, which we'll be totally ready for, but also some of the fees associated for the services. That's going to change. And again, we're ready to do that. But those are the two of the most recent ones that come to mind.
Thank you. And can you walk us through how a medical rebate would work, maybe using a cancer drug or something similar as an example?
Sure. Yeah, we can use, any of the products, maybe like a pegfilgrastim, which is, long-acting commonly stimulating factor. So when that drug is administered by a physician or infusion clinic or whatnot to a patient, they typically will bill those services to a health plan. The health plan captures that medical claim, and if they are qualified to receive a medical rebate on that product, they will submit it to the manufacturer themselves if they direct contract, or they'll submit it to us as part of the services. And what we'll do is we'll consolidate that claim or those claims for that health plan, and we'll invoice the manufacturers. The manufacturer will review the medical policies that the health plan may have associated with the use of that product. Once they say everything is good to go, they'll go ahead and pay a percentage discount on the cost of that product, and then we'll submit that back to the plan or the client in this case, and on a quarterly basis. So that's in a very basic nutshell how that works and how the timeline works.
And speaking of the cost side of things, rebates obviously are saving money, but for who in particular?
In particular, the health plan. Medical rebates apply only to entities that assume the financial risk for the product dispensed. So in this case, most of them are health plans that have that financial risk. Not always, but health plans are the majority.
And Sam, you're one of a handful of subject matter experts on the topic of medical rebates. How have you worked with Gateway clients on medical rebates, and how do these add value for clients?
Sure. It's been multifaceted over the last 6 years, almost 7 years now. When I started, there were a number of clients that didn't have medical rebate programs. Looking at their claims data and providing recommendations on that's the funnest part of it, really, is to highlight, hey, you can save some here, right? We also have clients that manage their own medical policies, which drive the use of the medications, and reviewing those and making recommendations to help them come in line with maybe fun aspects of that. But they're also key to providing savings. So that's really, giving the whole picture or providing maybe a whole picture of savings on drug utilization, not only from the pharmacy benefit, but also from the medical benefit as well, where sometimes the costs are not always as visible sometimes takes a little longer for a medical claim to process through a system. So when they see the savings opportunities, it's really eye opening. Also providing, just looking at utilization, providing recommendations around, hey, if you wanted to change strategy here, because this is where most of your utilization is at, or you can align and provide, get more savings for a product or products. That's been fun, and that's been the key thing that I've been doing for the last 7 years.
And where do you see the future going? What's in the pipeline?
The pipeline's pretty full of products right now. So the biggest thing that comes to mind is biosimilars. So this is not so much a new buzzword, but it's a big buzzword now in medical rebate programs, because a lot of these medications were the originator or used to be brand for a long time and were very highly utilized. So biosimilar adoption is important for us, and we include a lot of biosim in our program. So I see that accelerating in some very key classes in the next few years. So that's going to be a big one. Again, also, we talked about the cell and gene therapies. I don't see any slowdown in that. Now, their utilization's not as frequent as some of the other products. It's the cost associated with those products. So it's going to be key to look at the clinical data surrounding these cell and gene therapies, ensuring that, do they provide, some type of warranty or maybe a value-based outcome to ensure that they reach the outcomes they're stating or hoping for. And gene therapies continue to be approved and coming on the market. The costs associated with them are concerns to a lot of health plans. And then biosimilars. There's a number of those just continuing to enter the market each quarter, each year.
And Azim, do you have anything to tack on to what Sam said?
Yeah, well, Leslie, I think it's a great point that Sam made, and that pace of biosimilar adoption and penetration within the marketplace is accelerating for all the reasons Sam just referenced. But I wanted to also allude to a note that Gateway sent to all of our clients just yesterday. We're closely tracking some draft guidances. There's several draft guidances the FDA is looking at that's seeking to make the adoption and production of biosimilars less burdensome for manufacturers, because the issue was, a lot of these reference products or the originator brand products, they lose patent, and they just weren't having a lot of biosimilar manufacturers step up to the plate to make them because it was very onerous. There was a large burden in terms of cost and testing and time. And just because, a patent was expired, some of these reference products didn't have any competition. So what the FDA went ahead and did, and they have, again, draft guidance at this point, but hopefully it'll be pushed through in the very near future, is they were looking at a couple of things. They're looking to make the testing timeline a lot faster by requiring less burdensome testing and expensive testing and duplicative testing, and really seeking to make testing more simple and not necessarily as, heavily based on human trials, and more so what they're seeing in the lab in terms of, is this drug analytically similar and chemically similar to the reference product. So that's one thing they're looking at. And they're also looking to tackle interchangeability. The interchangeability being the issue of, can the pharmacist at the point of sale just, if a prescription is written for that brand originator, a biosimilar, or the reference product, can they just switch it for the biosimilar? In many cases, you can't unless it's deemed interchangeable. And that's got an even higher burden, because in order to get interchangeability, the biosimilar manufacturer has got to go through what's called switch testing or switching testing. And that it is expensive. It takes a long time. And then the FDA has to review all of that data. They're looking to lower that barrier entry as well, so that all biosimilars, unless there's some kind of clinical reason for a specific drug or disease state that kind of prohibits that ability. But for the most part, for most biosimilars, they're looking to be able to make most biosimilars interchangeable when they're approved. Again, it's not final yet, but these core changes that the FDA is making should make more manufacturers jump into the biosimilar space, adding to competition, leading to lower prices and lower net cost for patients as well as payers and plans. And it's fantastic news, because as Sam alluded to earlier, gene and cell therapies are only going to increase. The pipeline's full of them. These are the very expensive therapies. And we know legislation such as IRA encourages the production of, these specialty biotech products, because they have a longer runway in terms of, how long they can go before, negotiations begin on the Medicare D side. They get 4 additional years versus a simple or small molecule. So that's incentive for manufacturers to pursue research and development and production of these, very expensive biologic products. But the fact that biosimilars are gaining adoption right now and will accelerate even further due to some of the actions of the FDA is something we're following very closely, but also something that will hopefully free up some resources so we can pay for the miracle drugs of tomorrow that we're going to see.
Thank you, Azim. Sam and Azim, thank you for joining us for the April episode of Pharmacy Forward. To our listeners, remember that you can find us on Apple Podcasts, Spotify, and YouTube.